Symptoms are very common. I think the issue is that it's the don't ask, don't tell. So if you don't ask the patient, they won't tell you. It's incumbent on everybody in the dialysis team to assure that the patients are not having symptoms. I don't think that those symptoms should be okay, especially if you start going further in the literature and you start seeing more emergent data on there's more than meets the eye. It's just not maybe how patients may look, but how they feel, and those certainly has consequences internally. So I think that we have to have a better way of checking in on the patient, just how we do the checkpoints on the actual machinery, on the dialyzer, and double checking that the patient is on the right machine, on the right dialyzer. How did the patient do last treatment? The clinics are doing pain assessments. That's sort of a mandate. We need to be doing part of that pain assessment is symptoms. I think these are things that we need to be able to operationalize it and to be able to come up with some standardization that we feel is a valid instrument to really capture these quality of life metrics in real time for us to really be able to pick up on it. Those symptoms are very common, and I've heard patients describe them as sometimes hemodialysis. It really would puts the onus on the team to say, well, the patient's having symptoms. Just like if you had someone who's getting chemotherapy, if someone had symptoms, you would change the dose or you would do something different to your therapy. But if you're not engaging patients, you're not asking, they don't tell, you could keep doing what you're doing. And ultimately you could see there's very dire consequences. I think for a lot of nephrologists, they've sort of normalized that as being okay. And it's sort of, they get the symptoms and say, well, stop drinking water or stop eating and drinking. Rather than sort of saying, well, how do we make this therapy a lot more tolerable? If you get down to the quality measures and quality of life metrics, we know that that actually has a lot of effects on their overall mortality and outcomes, nutritional status, and there's been studies that have showed people who have symptoms, they'd rather have quality of life for X number of years and live minus years if they preserve that quality of life. You know, not so quality trumps quantity essentially. And so I think we've renounced, I think in the nephrology community that, you know, getting whatever hard clinical studies like we do in some drug studies, like we do in the cardiology field, I think that is unrealistic. It's a pie in the sky that we'll ever have sort of that hard evidence. And I think we have to sort of look at other intermediate outcomes and specifically look at quality of life metrics and look at things like true rehabilitations of markers like working, living. And I think those are things that I think with good methodologies that you could actually capture qualitative information, and you could, I think that that is probably where we could get down to some of those nebulous things that a lot of critics look at it and say it's either live or die. But you know, I think there's more that we do with dialysis than living and dying, and we certainly want to be able to thrive and have patients feel like that dialysis is actually helping them live versus the other way around. Intradialytic drops not only are impacting potentially what's happening to the myocardium, what's happening to the brain, what's happening to the stomach, but it also has an impact on symptoms and has an impact on sort of, we say, the recovery time. So, and then there's been some nice studies who've shown good correlation with recovery time and that. So I think that those are the parameters, and it's a constant challenge when you're trying to squeeze 7 days of eating and drinking into 3 days. And so I think that that gives you an opportunity to find out who are the patients who are unstable, who are not able to tolerate 3 times a week, and then looking at other options. So I've actually been very aggressive in saying, look, we don't take off more than X. Be very explicit. Say we're not taking off more than X unless you give them an extra hour of treatment and you could bring them back tomorrow, or you say, hey, let's model it for the week. If they're 3 times a week, you know, let's not hit a home run on Monday. Let's get a couple doubles. And then we'll get a couple doubles on Wednesday, and then we'll catch up by Friday. There's no need to hit a grand slam on the first day, and because that has consequences. It's very unstable, and oftentimes these patients are needing 4 days, 3 days, high ultrafiltrations, are going into the hospital for fluid overload, they're having complications of the treatment. You know, they're coming in with spikes and they're having sort of headaches, or they get home and they're going to the ER. So I think you can make a case that if you're providing a different approach, that you could identify patients that need more intensive dialysis, more intensive hemodialysis. Patients that we have been able to successfully transition into a more intensive, frequent therapy, the first thing they tell us, and the first thing that comes up, I think within the first treatment, it's like, this wasn't so bad. Wow. And you look at the parameters and say, well, we took off half that we normally take off because you're back tomorrow. So we're going singles. We're not doing doubles anymore. We're doing single, 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 single. There's many factors in a patient's medical history that will dictate how they do with the quote-unquote therapy that it's 3 times a week and that sort of experience. And then look at the clearances of middle molecules, look at their phosphorus, look at how they're doing with their minimal metabolism, because there's going to be advantages to be able to do longer therapies if you have to get, we know people with calciphylaxis, for example, we try to do them longer therapy, try to get them on a much longer nocturnal frequent therapy. And then you have small solute clearance, which I think is the easier one to handle. Again, if you're shooting for a low clearance right now with minimal clearance, but I think if you can deliver a much more longer therapy, a more consistent therapy, and you could somehow factor in getting enough water, I think the small solute clearance will just come along for the ride. You'll easily get to 1.2, and you might even get better than that. What is the patient's tolerability of the therapy? Are they having side effects? Are they having symptom-free dialysis? Is this therapy matching the needs of the patient, not just when they're on the machine, but when they're not on the machine? And then how it really pertains to their quality of life in terms of preservation of work, preservation of relationships, et cetera, et cetera. And so I think that these components we're talking about, I think are going to be easier to handle when you have a full menu of options to do. Nocturnal, short daily, length of therapy, time of the therapy, and I think the nephrologist should be excited about it. It's easy to sort of look at the metrics, look at the numbers, look at the machine, and oftentimes the patients sort of are in the shadows of this machine, and the machine is sort of at the center of what we're doing in terms of the calibration of the blood flow and the different convective clearances and the conductivity, etc. We need to be thinking about the therapy, because the therapy is there for the patient. The patients aren't there for the machines.
AdvancingDialysis.org is dedicated to providing clinicians and patients with better access to and more awareness of the reported clinical benefits and improved quality of life made possible with home dialysis, including more frequent, more intensive, and nocturnal therapy schedules. All forms of hemodialysis, including treatments performed in-center and at home, involve some risks. In addition, there are certain risks unique to treatment in the home environment. Patients differ, and not everyone will experience the reported benefits of more frequent hemodialysis. Certain risks associated with hemodialysis treatment are increased when performing nocturnal therapy due to the length of treatment time and because therapy is performed while the patient and care partner are sleeping. AdvancingDialysis.org is a project of Next Stage Medical Incorporated.